And now it has become a full public health problem. And this changing landscape demands a change in our approach also. So we can no longer just be satisfied prescribing glasses. We have to change the way we look at situations. We have to identify the children at risk, intervene early, and also give good analysis as far as the lifestyle changes are needed for the disease. And through this IC, we will be exploring the different options that we have for managing myopia holistically. And we will be covering a wide range of topics, ranging from the lifestyle changes which are needed for myopia, pediatric keratoconus, the optical management of myopia, as well as the effect of digital devices on the eye. And without wasting much time, we will start with the first topic. We will be starting with the lifestyle changes which are required in the prevention and control of myopia. So as we all know that myopia is in a pandemic proportion these days, and studies have predicted that half of the global population will be myopic and 1/10 will be highly myopic by 2050. India too is witnessing a sharp rise in myopia, with the numbers rising rapidly across all age groups, particularly among school-aged children, and the prevalence is expected to rise from 20% in 2020 to about 48% in 2050. That is, almost 1 in 2 Indians may be myopic by 2050. So the effective management always starts with accurate risk assessment, and higher the risk of onset, we need to identify the high risk of onset, and that is in parental history of myopia, East Asian ethnicity, excessive near work, and limited outdoor time. And the risk that the child may become myopic becomes threefold if one parent is myopic, and sixfold if both the parents are myopic. Higher risk of progression is seen with early onset myopia when it starts less than 9 years of age, and parental history, limited outdoor time, and excessive near work further compound it. High myopia is more likely to develop in cases with early onset and rapid annular progression, that is more than 0.75 diopter per year, and children with multiple risk factors should be identified early and offered timely and effective myopia control measures. So while genetics may initiate myopia, external factors collectively drive its progression, and these factors can be visual behavior related, like prolonged near work, excessive screen time, and inadequate visual breaks, environmental factors like reduced outdoor exposure and low ambient illumination, lifestyle factors like the years spent in school, nature of occupation and housing conditions, and also nutritional and dietary factors like the vitamin D levels, the protein intake, and the role of antioxidants. The good part is that most factors influencing myopia progression are modifiable. Among the modifiable risk factors, outdoor time has consistently shown a protective effect against the onset and progression of myopia. Outdoor time during childhood reduces the risk in young adulthood. Studies have shown that outdoor time during adolescence reduces the risk of late onset myopia. 45 minutes of structured time outdoors causes 25% reduction in new cases of myopia, and most importantly, outdoor time of more than 2 hours a day leads to regression of myopia. So encouraging outdoor time is simple, most cost-effective strategy for myopia control. Singapore was one of the earliest countries to recognize myopia as a public health issue, and in 2001 the government launched a myopia prevention program. The aim was delaying the onset rather than just correcting the refractive error. Multiple interventions were made, and the most successful was increasing the outdoor time. It was found to be more effective even than atropine drops. Now, how exactly does outdoor prevent myopia? Outdoor exposure reduces myopia progression by a combination of biological and optical mechanisms which reduce the axial length elongation. The outdoor light is high intensity, blue-rich, and full spectrum. So this helps in circadian rhythm regulation and thereby increases the retinal dopamine level. The uniform dioptric field reduces the hyperopic defocus. The smaller pupil size causes less blur and a clearer image. It also improves contrast sensitivity and photoreceptor activity, thereby reducing the accommodative stress. And the sunlight itself is a natural source of vitamin D, which is protective against myopia. Also, we need to keep in mind that different wavelengths of light have different effects on the axial elongation of the eye. Blue light tends to inhibit the axial elongation, while the red and green wavelengths usually found in indoor lighting may promote it. Also, studies have found that the daily exposure to outdoor light more than 3000 lux has been shown to reduce axial length growth in children, and lesser myopia progression was observed in summer months as compared to winter months. Myopia progression is very closely linked with the circadian rhythm. Light exposure increases dopamine and reduces the melatonin levels. The dopamine acts as a stop signal for myopic elongation, and disruption of the circadian rhythm and poor sleep disturbs this balance. Higher morning and daytime melatonin levels have been associated with axial elongation and myopia progression. Now, vitamin D also works on structural, functional, and biological pathways. It increases the collagen synthesis, thereby increasing the scleral rigidity and decreasing the axial elongation. Vitamin D receptors are also found in the ciliary body, which helps in optimizing ciliary muscle action, which leads to better accommodation and clearer image. And the anti-inflammatory effect causes the reduction in the chronic ocular inflammation, thereby reducing abnormal eye growth. Now, coming to task lighting or indoor lighting. Task lighting is the artificial light used to increase visibility for activities such as reading, and good task lighting means adequate illumination on the work area with minimum glare. Studies have found that most households have inadequate lighting, and brighter classrooms were linked with a lower risk of myopia compared to dimly lit ones. The studies concluded that poor lighting encourages closer viewing and myopia progression, while the brighter environments are linked with slower axial elongation. So coming to near work is a significant risk factor, and the odds of developing myopia increase by 2% for every diopter hour of near work per week, and shorter working distance and longer duration increase the risk. So the excessive near work leads to accommodation lag, which causes a hyperopic defocus, which leads to axial elongation and thereby myopia progression. Studying habits also have an impact. Sustained near work, frequent accommodative changes due to swaying or shifting posture during study, and variations in the print size, which leads to repeated focusing stress, contribute to myopia progression. A positive association between educational load and both the prevalence and severity of myopia has been found. Screen time, of course, is the silent villain. More than 2 hours of daily screen time is a high risk factor for myopia progression. Therefore, cap the screen time to less than 2 hours, and children less than 2 years should have as little screen time as possible. High prevalence of myopia was found among workers with a short working distance, making occupation an important risk factor. And studies comparing urban and rural settings found that urban children have higher rate of myopia and anisometropia and lower rates of hypermetropia than rural children. Housing time also has an impact on myopia development, and apartment and high-rise living is linked with higher risk of myopia due to the limited outdoor exposure and distance viewing. Diet alone cannot prevent myopia, but it can support other measures in slowing the progression. And it has been found that vitamin D, omega-3 fatty acids and antioxidants seem to have a protective role, and processed food and low protein intake seems to enhance the risk. Now coming to a very important entity, the adult myopia. Adult myopia is not just a refractive error, it's a response to the visual environment. It presents during adulthood, more than 18 years of age, and it is usually low to moderate. The contributing factors are prolonged near work at short distance and a high accommodative lag. Counseling is critical in these cases because the patients must understand that adult myopia can progress and needs monitoring. They must be counseled on good visual habits, good lighting, proper distance, 20-20 breaks, and daily outdoor time. Now this is it is very clinically relevant because increasing axial length can present as post-LASIK regression, and therefore always measure axial length before surgery to distinguish between progression as well as regression. It is important to assess corneal curvature to rule out ectasia in these cases, rule out pseudomyopia, and rule out retinal pathology. The take-home message here is that lifestyle matters in both the onset and progression of myopia. More outdoor time and less near work, especially screen use, helps to slow myopia. While genetics and age of onset are non-modifiable risk factors, lifestyle choices are modifiable and significantly influence the progression of myopia. Thank you, and thank you for your patient listening.